Well, we're just at 8 a.m., so let's get started. Delighted to have Dr. Raval as our guest speaker. And as our guest introductor, we will have Shika Jha, who is one of our senior cardiology fellows, to do the introductions. So, Shika, who is also featured at our last, one of our recent grand rounds for her artwork. So, delighted to have you.
Thank you so much. Well, good morning, everyone, and happy Friday. Welcome to the Department of Medicine Grand Round presentation. My name is Shika, as you know now, and I'm a third year general cardiology fellow. Thank you, Dr. Schnapp and Medicine Department, for giving me this opportunity to moderate the Grand Round session today. It's my extreme honor and privilege to introduce our speaker for today, Dr. Amish Raval. Dr. Raval completed his medical school from Western University in Ontario, Canada, where he also completed his internal medicine residency and cardiovascular medicine fellowship. He further trained in interventional cardiology and vascular interventions from Georgetown University in Washington, D.C. He completed his postdoctorate fellowship in interventional MRI and cardiac and peripheral interventions at NIH. He has remarkable track record of outstanding leadership in the field of medicine. He's the active chair of the steering committee of National Cardiac AMP HF Pivotal Trial. He's the board chairman and founder of Cellular Logistics in Madison, Wisconsin. He serves as the chair of Scientific Focus Group on Cardiovascular Regeneration at UW. He's the medical director of STEMI program at UW and has been recognized several times with Get With the Guidelines Platinum Award for his STEMI program excellence. He's the former director of UW Clinical Cardiovascular Regenerative Medicine, and he actively holds this prestigious title of Jack and Margot Ed Professorship in Cardiovascular Medicine and Interventional Cardiology at UW. Dr. Raval has multiple publications, multiple book chapters, editorials, as well as co-authorship in some of the national clinical guidelines and scientific statements. He's a pioneer in the field of innovation and research. He has been invited as research presenter at several regional and national scientific meetings. He presented the results from CardiAMP HF trial this past year at ACC 2025 late-breaking clinical trials. Dr. Raval's area of passion also includes structural heart disease and, of course, stem cell innovation. He played a strong role, especially in establishing the TAVR program at UW. He is well renowned for his dedication and enthusiasm towards medical education and mentorship, especially for his trainees, residents, and fellows, of course. And besides his countless academic, clinical, and research accolade, he is a gem of a human being. He's highly respected and admired for his calm demeanor, utmost professionalism, and kind attitude towards his colleagues, staffs, and of course, his patients. As a trainee, I'm fortunate and proud to call him my attending, my teacher, my mentor. Please join me in welcoming Dr. Amish Raval. Today, he will be presenting his talk on cardiovascular regenerative medicine's lessons learned, clinical directions, and challenges ahead. Dr. Raval, the stage is yours. Thank you.
Thank you, Shika. I'm glad this is recorded because I'll play this over and over again. What an introduction. Thank you so much. Let me just go through some of these beginning slides. These are my conflicts of interest. So we're going to talk about lessons learned, clinical directions, and challenges ahead as it relates to cardiovascular regenerative medicine. So here are our learning objectives to summarize four main pillars of HFrEF treatment. List some of the major constituent cells that make up the healthy heart and identify delivery methods for cell therapies and explain some of the roles of cardiac extracellular matrix in development, homeostasis, and repair, and identify cardiac regenerative medicine therapeutic targets that are currently in clinical development. And so here's the background. The myocardial infarction affects so many. Most of you, if not all of you, will see a patient who has been affected by myocardial infarction in their past, or have had a personal involvement of a family member, a friend, or a neighbor. It's such a common condition. One American has an MI every 40 seconds. Over 800,000 Americans have an MI every year. So it's very common, and large MIs and repeated injury causes this. So an obstruction forms, a cholesterol plaque builds up, plaque ruptures, clot forms, and it leads to a significant amount of damage. And that damage can affect the myocardium here, leading progressively to thinning of that scar, decreased function, of the healthier parts of the myocardium, particularly at the border zone area, progressive left ventricular dilatation, predisposition to arrhythmias, and of course, sudden death. In addition, it leads to this condition called congestive heart failure, which is going to be the thrust of my talk, ischemic congestive heart failure. Like this show, I really go through pathways that the myocarditis initiate cardiocrosis. But can simplify it. There's this pair phase that happens. That pro-inflammatory phase is cell-mediated, neutrophils, lymphocytes, so forth, a lot of cytokines. And the anti-inflammatory phase starts to instill certain cytokines that are more reparative, like TGF-beta, IL-10, and leads to some ECM remodeling. And the reparative phase is related to cardiac fibroblast proliferation and collagen deposition leading to scar. And that reparative phase is sort of adaptive. And that's the reason why uh, that cardiac perforation following myocardial infarction, so spontaneous perforation, remains rare because the scars formed affirms it, and it's really kind of an naturally adaptive protection mechanism. But it's late maladaptive, of course, because it leads to progressive enlargement and heart failure. So that's the mechanism. It's been pretty well described. Most of the descriptions of the mechanisms that surround cardiac remodeling post-MI have been done in mice. But this is a human, and this is a patient that I managed initially with his MI. 4 months later, I saw him at follow-up. Sorry. And this was the MRI that ended up being done, showing a very large MI with thin myocardium, large dilated ventricle. And this is the delayed enhancement showing a complete MI. Unfortunately, this patient passed about 6 more months later. And so this is the condition that we struggle with. Now, 8.5 million people are expected to have heart failure by the age of 2030. That said, that is a combination of both uh, heart failure with preserved ejection fraction, heart failure with mildly reduced ejection fraction, and heart failure with reduced ejection fraction. The HFrEF population is expected to be about half of that 8.5 million. So it's still quite a large number in the burden. So contemporary heart failure management really has relied historically on these sort of areas, pharmaceuticals, devices, revascularization, and transplant. Major headways have been made, and inroads have been made in the pharmaceutical business. We are no longer just limited to Lasix and digoxin, which used to be the kind of tried and true for many years and decades before. We now have the so-called 4 pillars of therapy for heart failure. You'll notice digoxin's not in there. You'll notice that diuretics aren't in there because they're not really well demonstrated to demonstrate mortality benefits. These medications are demonstrated to have mortality benefits in this patient population. The more of these medications that can be applied and the more rapidly they can be dose titrated, the better. Other techniques or therapies include devices to resynchronize heart contraction. Ventricular assist devices have come a long way, the HeartMate 3. And now we're at a stage of repairing and replacing valve conditions as older patients can also have coexisting valve conditions in response to the ventricular dilatation. So mitral regurgitation, tricuspid regurgitation is often kind of goes along with heart failure. I'm actually here in Milwaukee learning how to do a new technique that hopefully we'll bring back to UW next week in a couple of patients to repair the tricuspid valve, or replace their tricuspid valve. So new innovations have occurred in that area, and of course, opening the arteries is also improved. We have better stents, we have better techniques and methods. The surgeons have better techniques for revascularization. Of course, heart transplant, immunosuppression, medication selection have all improved. However, we have this heart failure paradox. And what is that? Well, we've learned a lot about cardiac remodeling and the lead towards heart failure. We learned a lot about the mechanisms behind some of the therapies and the technological advances. However, we still have persistently poor patient population level outcomes. And so new approaches have to be considered. And that's really the foray towards cardiovascular regenerative medicine, to think about all of this in a tissue level approach. And so to be able to do that, one has to consider what are the various cell types that comprise the heart. So these are the major cell types that comprise the heart. These cardiac fibroblasts being the most abundant, cardiomyocytes, smooth muscle cells, and then of course immune cells. The extracellular matrix that helps to bind all of these cells and interact with those cells is super important for maintaining homeostasis, and is critically involved in tissue repair as well. The first efforts in cardiovascular regenerative medicine back in the late 80s and early 90s were related to angiogenesis and improving calcium handling as a decade forward. For example, VEGF, vascular endothelial growth factor, known to induce angiogenesis in animal models, was administered in patients, as was trying to restore circuit 2A calcium channel, the sort of calcium handling in the cells. However, these more gene and protein-based therapies failed to show their benefits in clinical trials. And why was it? What were the lessons learned? Well, inefficient myocardial delivery, the products weren't really staying very well in the myocardium. Transient expression of the particularly of the defect off-target produce spatial, temporal, and multifunctional signaling required for coordinated tissue repair. So it just means that these simplified, narrowed down kind of single target approaches just didn't work. So newer approaches are needed. And one approach to take on the failure to reproduce spatial, temporal, and multifunctional signaling is to use cells, with the notion that maybe injecting cells makes things, their cells are smarter than drugs or small molecules, and or transfection factors. And so, cell therapy then came to fruition in the sort of the early 2000s. And I have been thinking about this for some time, and think about different ways that cell-based therapies have been used and are utilized. And it's conceptually, it's simpler to kind of think about this in three different domains. Cells that can condition the heart. So these, can maybe create new blood vessels, immunomodulate things, prevent, cell death, kind of create a conditioning environment through the release of paracrine release of cytokines and growth factors, or using cells to help support the heart. This is work by Eric Schmuck, where he was taking extracellular matrix derived from cardiac fibroblasts from donors, and then producing these biomaterials, extracellular matrix biomaterials that can be placed as scaffolds, or it could be dried and fragmented into and then resuspended into an injectable, to help support the myocardium. And then, of course, to replace heart tissue. These are large human cell grafts in a monkey that has undergone a myocardial infarction, showing huge grafts here after 1 billion cells replaced. Dr. Tim Camp is pioneering his work in the use of pluripotent stem cells, especially induced pluripotent stem cells, to create these beating cardiomyocytes. So the notion there was maybe that we can inject, administer, and replace myocardium. And of course, this is too simplistic a model. Some of the cell types that have been tested in preclinical and now clinical studies may have aspects or elements of each of these three different domains. But boy, it gets complicated. I'm a clinician as well. My interest in all of this is trying to see these therapies through to clinical trials. And as I think about cell-based therapy, we think about all of these different elements: potency, retention, engraftment, immune response, dose safety, stability. And so as I have my beer and smoke my cigarette, I think about, what could my contribution be in this area? And as an interventional cardiologist, I focused on the delivery aspect. And many years ago, our group and others, of course, have described many different ways of how we could deliver cells, as simply as an intravenous infusion, to a more complex, invasive open thoracotomy surgery, where whole scaffolds could be used to, repair and replace the myocardium. But really, as the field has evolved, the notion that we do things very invasively has become less in these sick patient population. And really, the target goal for us in the delivery world is what can we do minimally invasively? How can we get the cells to the targets of interest, whether that's the scar itself or in the border zone? And how do we get the cells to retain? Now, retention and engraftment are totally separate things. Engraftment is about how we get the cells to integrate in the myocardium, but they won't integrate if they don't actually stay there with some persistence. And so that's been our focus in our lab for many years. There are many different ways to consider this. Intravenous approaches have been studied, of course, but the cell retention is very low. Intracoronary infusion, injecting it through using catheters that we're very familiar with, right into the coronary artery, has some limitations itself, can plug up microvascular vessels and make the injury even worse. Transvenous, going backward through the coronary sinus, as well as epicardial through injectable through the surface of the heart, maybe not through a whole sternotomy, but through a thoracoscopic approach, have all been kind of described. But when we look at cell delivery and retention, again, our group and others have been studying this for some time, and it seems that intravenous delivery, coronary sinus delivery, all of these infusional approaches have very low retention over time. And this is percent retention in the y-axis and over time. And so we're talking hours. This isn't like 20 days or 20 weeks. This is hours of how many cells actually injected into the coronary artery actually stay there. So for the most part, the retention is very low. There's one outlier in this paper, but that is an outlier. But most of us have now steered towards this transendocardial delivery. What is that? That is a catheter that's fed typically through a femoral artery across the aortic valve retrograde into the left ventricle, and a needle is injected into the myocardium from the inside. So it's less invasive. There's a variety of different needle options out there, all investigational, that have been studied in various forms. And when you look at the retention properties, yeah, still a challenge. We're still not getting there, but we're a little bit better than some of these other approaches. How do we get the cells to deliver to the target areas? Well, the mapping systems that have been used in the past, the most commonly used one was electroanatomic mapping. That is a GPS, magnetic field generator with a GPS coil to monitor the catheter, to be able to take a catheter and create mapping points to outline what the ventricle looks like, and then to be able to steer the catheter that has a GPS tracker on it as well within that field. And this approach requires a mapping step that takes about 30 minutes to 60 minutes. This was the initial phase. This is something that if you're familiar with electrophysiology, you may know that they've been using this kind of technology for a very long time. And these maps have now improved and gotten much better, but there's still today no other direct injection needle catheter like this that's can be integrated within a mapping system. Unfortunately, this particular vendor's mapping system, they discontinued about 5 years ago, citing economic reasons for that company, and also lack of efficacy, frankly, of cell therapies that had to that point not really worked. And so we didn't have anything for some time, and even getting access to this mapping system was challenging. So we took it upon ourselves several years ago to create our own mapping system in light of that. Something that we think was efficient, accurate, interactive, and vendor independent. That was kind of our goals, and we were able to accomplish that. And so what we did was we took in pig models of MI, we took MRI, pre-acquired MRI scans, created a three-dimensional image from them, a rendering of the endocardial surfaces and the scar surfaces, and then registered and overlaid that onto an X-ray fluoroscopy platform, the cath lab. And here you can see in a pig model, the red being the endocardial surface, the yellow being the scar, and the catheter going in and injecting. And all the blue dots are where the previous injections were. And we can kind of render that separately on the screen here, and then create a bullseye plot to kind of look at our kind of distribution around the scar. Our goal for this project, in this pig project, was to inject as close to the border zone as we could. And so we use this catheter to help with retention. As you can see, it's a needle tip catheter that's got a corkscrew shaped end, and it allows for drilling into the myocardium so that when the payload is delivered off the tip, when we undo the catheter out of the myocardium, the payload stays there. And so studies have been shown that this approach has a better retention aspect than straight needle catheters. We integrated this within a clinical system, so once still in pigs, still not FDA approved here in humans, but we did this on a clinical system, and we injected iron oxide labels, and we proved that in at least in vivo that the iron oxide labels seemed to match the histology where we wanted to inject and where we ended up injecting. And we measured retention properties of cells by labeling them with FDG and did a PET scan and showed deposits of, this is one injection, kind of a blooming injection of cells here, and showed with this approach with the mapping system, with the corkscrew shaped catheter, and using mesenchymal stem cells in this particular case, we could show retention properties of greater than 60% at 2 hours and greater than 40% at 6 hours. So better than, but still not perfect. We tested this approach using this catheter system and these particular cells, mesenchymal stem cells from pigs, in a porcine trial. And we did what we called a prime and boost. So we thought that, well, maybe the intravenous approach of mesenchymal stem cells could be anti-inflammatory. That notion kind of stems from some of the work done in graft versus host disease from some time ago, that we can kind of create a better milieu, and then about 14 days later, take that catheter, go back into the heart, and give a second dose. So the minus is first dose, and the next minus is second dose, and this is the control group. This is the IV, and then we actually IV control, and we actually placebo, and we actually gave cells in this transendocardial, and this is the IV plus transendocardial. And you can see the contractility reserve progressively increases with the cell treatment with transendocardial therapies compared to the control. So now there are a lot of different cell types that have been tested in clinical trials for adult cell therapy. And the problem has been that none of the cell types have actually made it to clinical care. Initial foray of using skeletal myoblasts was kind of an initial promise, because these are easy to obtain, easy to culture, easy to administer. However, in the heart, taking leg cells or muscle cells from the leg and placing it in the heart is a surefire way of causing arrhythmias. And that was really what kind of shut down those programs. The next foray was looking at cardiac-derived cells that you could harvest from the heart, expand in large numbers, and inject back. And that was all very well and good, but the processing required to do all of this is just so daunting. And to maintain quality and consistency was really the death knell of this approach. Bone marrow cells, on the other hand, are easy to acquire. This technology of aspirating bone marrow has been around for decades, and it contains a large populations of cells that have very favorable properties, and more about the conditioning aspects, paracrine-related influences on heart repair. And this is the area that kind of stuck for a while, and the area of focus, kind of what we took on afterwards. Now, autologous bone marrow mononuclear cells may have certain mechanisms. As I mentioned, there are a variety of markers that kind of define cells that seem to have properties that are beneficial. They seem to release growth factors, cytokines, and these growth factors and cytokines can be bundled up into exosomes and vesicles. And we can then inject the cells and hope that these products can be elicited in the tissues. And sure enough, in preclinical studies, bone marrow mononuclear cell therapy has been associated with increased vascular density, reduced apoptosis, decreased fibrosis, and immunomodulation, where macrophages go from a very pro-inflammatory phenotype to a more of a pro-reparative, anti-inflammatory phenotype that's favorable. So with that, principle in mind, many studies were done. About 700 patients in this particular meta-analysis were studied in 14 randomized controlled clinical trials. Sample sizes ranged from about 15 to 200. Bone marrow cell transplant was associated in aggregate with overall improvements in left ventricular ejection fraction, improvement in New York Heart Association class, improvements in 6-minute walk distance, but there was no safety concerns. However, the holy grail of trying to improve death and heart failure rehospitalization was not able to be achieved, although they were kind of generally trends. Now, it's important to note that bone marrow mononuclear cell therapy were mostly just taking unfractionated autologous cells right from the patient right back into the heart. When we think about that, what are the cons of the approach? Well, the cons, as a clinician, you want to see results. And unfortunately, the trial results were kind of mixed, especially for the harder endpoints of mortality and heart failure rehospitalization. But there's also the challenge of if, okay, we have cells within them, we know, and within the mixture of bone marrow, we know those some of those work, and why don't we just select those? But those cell selection strategies were costly and difficult to ensure quality and disseminate it broadly across the country. And so that has become, it's still around, but it's not as favored. But there are some pros towards the generalized approach of taking bone marrow mononuclear cells. There's a lot of favorable preclinical evidence. It's very simple to harvest. It's minimally manipulated, so there's not a lot of regulatory concerns. There's really no concern for rejection because we're talking autologous. And generally speaking, in this healthcare climate where we don't have a lot more tolerance for very expensive things, it's low cost. So based on that predicate, we came to the question of, well, can autologous bone marrow mononuclear cell injections in these patients particularly in patients who possess themselves favorable bone marrow cell characteristics. So maybe the enrichment strategies here, taking it out, manipulating it, and so forth, is not really the right approach, but maybe we can identify those patients who are likely to be responders. And maybe that will improve heart failure outcomes. And so we took on this clinical trial, major clinical trial, 25 activated centers in the United States and Canada called a CardiAMP heart failure trial. I was fortunate enough to be the national co-PI along with Dr. Carl Pepin at the University of Florida, Gainesville. And you will know that the University of Wisconsin here was the data coordinating center and also the lead towards the Data Safety Monitoring Board. So we took patients who had New York Heart Association class 2 and 3 ischemic heart failure, ejection fractions of between 20 and 40%. And they had to have a kind of a narrow window of their baseline 6-minute walk distance of between 100 and 450 meters. And we discussed this internally. This was actually a proposal by the FDA, a strong suggestion, and we discussed it, and we couldn't think of a reason why we shouldn't do this. And so we kind of included it, but as you will see in a minute, it ended up being a mistake. We took these patients, we did a cell collection of bone marrow. We processed those cells in the same setting in the cath lab, and then we delivered it using the transendocardial catheter approach. So it's a very patient-centered, point of care approach, very low cost and efficient. We published the rationale and design and the results of a rolling cohort as well. And we packaged up a kit that included a mononuclear cell separator, really using Ficalt techniques, fairly simple. The bone marrow needle, the catheters, the syringes, all the kit kind of to put it together and make it very practical for sites that maybe weren't really facile in the cell therapy world to kind of do and make it seamless. And the study objectives were to determine the safety and effectiveness of this system for treating ischemic heart failure patients. It was a randomized 3-to-2 double-blind control procedure control. So it was actually interesting. We had a sham procedure, pretended that we were injecting. We did still get vascular access and so on. And the study focused on patients whose cell met pre-specified cell population thresholds based on previous study. A cell characterization assay was developed. A sample of that bone marrow pre-acquired was sent to Baylor for independent analysis. And then we were given a thumbs up or thumbs down on that patient, whether or not they carried the cell population yields that we thought would be beneficial. And so the primary outcome was also kind of innovative. It was a hierarchical composite ranking of tier 1, tier 2, and tier 3 events. Tier 1 being all-cause death, cardiac transplant, left ventricular assist device. We consider that kind of like a cardiac death equivalent. Tier 2 were all non-fatal MACE events as defined by heart failure, hospitalization, MI, or stroke. And tier 3 was that 6-minute walk distance from baseline to follow-up. And And then we did have a pre-specified secondary effectiveness analysis of a quality of life measure, the Minnesota Living with Heart Failure questionnaire, as a kind of secondary effectiveness outcome for tier 3. We used a win ratio analysis to help with the primary endpoint in the design. For those people who don't know, a win ratio analysis is now becoming quite common. It allows us to create sort of composite endpoints when you have categorical variables like death and MI and hospitalization, and you want to kind of combine it with a continuous variable like a quality of life questionnaire or a 6-minute walk distance. And what happens in this win ratio analysis is patients from the treatment arm are identified initially and then randomly compared against patients in the sham arm. And during that computational randomization, these event rates are all compared. So tier 1 is first, if one is clearly outperforming the other in tier 1, it stops. But if they're sort of similar in the head-to-head comparison between the treated patient and the sham patient, then it goes to the next tier, and so on down to tier 3. And the planned sample size using this approach was 250 patients total. And so here's what was happening. And as Chika mentioned, this was I had the fortune of being able to present this at the late breaker at American College of Cardiology meeting. We screened in the country 303 patients in 25 sites in the United States and Canada. A total of about 38% of the patients failed their cell population analysis, about a third. And that's kind of what we predicted based on the literature. About a third of patients would not really. There are a few other patients that were excluded based on other criteria as well. However, the study was paused at an interim about 2 years later, about 5 years later, because of two reasons. One, we were trying to enroll through COVID-19, and as you know, a lot of research kind of paused through there, and so the recruitment rates were just really abysmal. And then the second reason is that the 6-minute walk test distance was not permitting us to be likely to be favorable as a primary endpoint, being favorable given the results we were seeing. And what was happening is that there were a lot of patients that were coming in as their baseline 6-minute walk test distance of about 440 meters, but then in their follow-up phase, it was just super high. So we think there was probably some sort of an underperformance bias happening. So people were trying to game getting into the trial. So that became kind of a challenge for us and created a lot more variability. Not only that, but also the variability of trying to do 6-minute walk test distances during a pandemic. And so ultimately, at the pause, the study sponsor decided to stop enrollment at that point and just do a full analysis of what we had. And that was 115 patients total taken out to 2 years. The baseline characteristics of those patients were very similar. The mean age was about 65 years old. The left ventricular ejection fraction was about 32%, kind of a 73% class 2, 27% class 3, balanced between groups, and very good, generally very good. And this is actually pretty good considering for a heart failure trial, utilization of guideline-directed medical therapy for heart failure at the time. The safety, there were no safety endpoints that were of particular worry, except for 3 patients did develop pericardial effusions, but all were successfully drained and all completed 24-month follow-up. The primary efficacy outcome at 2 years, however, showed that the tier 1 events were numerically favorable for the treatment arm compared to the control arm, whereas the tier 2 events similarly were numerically favorable for the treatment arm versus the control arm. However, the 6-minute walk test distance went in the other direction, and this is what kind of dragged down the entire win ratio to 1.01, which is neutrality with a non-statistically significant p-value, of course. And if we look at this study from the perspective of more traditional way of looking at it, MACE-free survival, we do see for the MACE events, as we saw earlier, the treatment arm had fewer MACE events over time than the control arm patients, though not statistically significant given the numbers. And if we drill down even further to all of the different endpoints that comprise MACE, you can see improvements in the treatment arm numerically compared to the control, but again, not statistically significant. And if we look at the secondary endpoint, where we looked at the Minnesota Living with Heart Failure questionnaire, again, not the primary, we see wins across the column from tier 1, tier 2, and tier 3, but just with the 115 patients, not quite statistically significant, but the win ratio is starting to climb here. And then if we now take a subgroup of those patients and we say, okay, well, these are class 2 and 3 patients, but what if we only look at those people who had elevations in their NT-proBNP or BNP, and we looked at the median, and that ended up being over 500 picograms per deciliter. And if we looked at that group, that ended up being a small number, relatively small number, 35 in the treatment and 22 in the control. You can see that the wins, the win ratios for the tier 1, tier 2, and tier 3 favored treatment when you took into account the 6-minute walk test distance on the right side. But if you switched over to the Minnesota Living with Heart Failure questionnaire, which would be, potentially less susceptible to the underperformance bias because it was not part of the entry criteria, now we're starting to see a statistically significant improvement with a win ratio of almost 2. But again, small sample size. And if we look at the individual endpoints, we see a smaller, reduced numbers of patients with fewer MACE events in the treatment arm versus the control arm, sort of being, again, more compelling that maybe this is the right patient population to look at. More recently, we have now done the echo portions of the echo analysis, and we'll be presenting the entire echo analysis at the Transcatheter Heart Therapeutics meeting in Boston as also part of the late-breaking clinical trial session. And we're now seeing that in the treatment arm, we see a blunting of the left ventricular end diastolic volume over time, whereas in the sham arm, the left ventricular volumes, both end systolic and end diastolic volume, are climbing as you would think they would with remodeling. And if you look at the NT-proBNP population, that difference is even more significant, again, lending to the mechanism that these patients seem to be getting better symptomatically, fewer heart events, but also their ejection fractions and their volumes are improving. So this trial has been invited for expedited submission at JACC, which we've done, and now we're getting review comments and responding to it. The overall summary of it was that the personalized point of care approach was safe, but failed to meet the primary endpoint. The pandemic and this baseline 6-minute walk test underperformance bias kind of hurt the trial and interpretation, but numerical improvements in several key outcomes, including remodeling and disease, I think need to be further explored and maybe an opportunity to enrich the patient population even further using only those patients, testing us on only those patients with elevated NT-proBNP or BNP. And so this was the motivation behind the CardiAmp Heart Failure 2 trial. We're not particularly innovative in our in our naming, but similar sample size, 250 patients, and similar patient population, except we're going to now take patients with an elevated NT-proBNP, and we're going to switch the tier 3 to a Minnesota Living with Heart Failure Quality of Life questionnaire to really try to confirm what we suspect from the Heart Failure 1 study. And this trial is active and ongoing. So that's the notion of what we are. That's and if this trial becomes is positive, and given the FDA's response of it as a breakthrough therapy device, this may end up being the very first cell therapy for cardiac disease in humans. And so this is pretty exciting stuff. Now, let's look behind the curtains very quickly in terms of what we're doing internally on the 8th floor at Wimmer, kind of thinking futuristically. And we're kind of focusing on two areas: committed cardiac progenitors and cell-free biomaterials. And the motivation behind this line of work stems from work done in the past by others injecting embryonic stem cell-derived cardiomyocytes and into the heart. And this was 1 billion cells into a macaque monkey, showing huge graphs here, but 1 billion cells, which is not a trivial task for manufacturing. And here, hundreds of millions of cells, also showing human cell grafts in a pig model, and this is the monkey model. So human cell grafts in monkeys and showing these graphs. However, the challenge was huge amounts of arrhythmias. These animals were having ventricular tachycardia sometimes for hours or days at a time because of the lack of integration or misintegration that's occurring. The other problem is these animals have to be, for a xenogenetic transplant, have to be severely immunosuppressed, chemically. And so that leads to other challenges. And of course, the ethical challenges of injecting embryonic stem cells make it less appealing in terms of a clinical pathway. And so our group and others, Jamie Thompson and Shinya Yamanaka, developed an induced pluripotent stem cell model by genetically editing cells to take on an embryonic-like phenotype. And Tim Camp and others have been able to take those cells and being able to make a variety of different cell types, including cardiac myocytes, fibroblasts, and epithelial cells. But an interesting cell type called a cardiac progenitor cell, sort of the step before the development of a cardiomyocyte. And these cells might have the ability to become the cardiomyocyte, smooth muscle cells, and endothelial cells, but also release certain factors and proteins that could be favorable in a post-MI environment. And so Tim Camp published this paper that shows a nice diagram of the potential for cells to be plated, cultured up, and banked, and then thawed and resuspended as an injectable or as a tissue scaffold or a patch to be going back right into the heart via a variety of different approaches. The challenge would be to how do we get the dose high and scalable? I mean, this is possible now. It would be less possible with adult cells. And how do we improve? And will this remuscularize and will this cause arrhythmias using this pathway? And in particular, the committed cardiac progenitors that haven't yet become cardiomyocytes. And so, in collaboration with Fujifilm Cellular Dynamics, a process was put in place, and I won't go through all the details, to get these committed cardiac progenitor cells, culture them up to high numbers, and then be able to deliver them. And in parallel, as mentioned earlier, Eric Schmuck was working on extracellular matrices that could be then dehydrated and fragmented into little particles, and you could then bind cells to them, and they just have a very adherent and sticky property. So these GFP labeled mesenchymal stem cells just kind of glom onto these little particles. So maybe this is our answer to really boost retention. And he demonstrated this in a rat by injecting labeled quantum dot labeled mesenchymal stem cells along with particularized ECM into the myocardium of the rat versus the cells alone in blue. And the cells alone in blue, you start to see these little streaks, and they're probably escaping out the pathways of the veins and lymphatics. This matrix seems to be very unique because it's not unlike many other matrices that have been kind of developed out there, which are mostly collagen based. This one is almost entirely fibronectin in its content. And so fibronectin is a very important developmental protein. So a glycoprotein. So it may have some favorable benefits on its own. And to that extent, he has cultured these matrices along with monocytes to create these sort of polarized macrophages. And it was able to show in vitro that the matrix itself in yellow does not express as much of the inflammatory markers, and in fact has anti-inflammatory properties and might express greater amounts of VEGF and IL-6, which could have favorable benefits. IL-6 is a pleiotropic protein that definitely has some inflammatory properties in certain settings, but can be pro-reparative in other settings. And then injecting the matrix into a mouse model post-MI in a dose fashion seems to improve contractility. So these are pressure volume loop measures of load-independent contractility showing improvements in a dose-dependent fashion. So Eric's done a really great work, and that manuscript's in progress. We took that concept of this matrix and these committed cardiac progenitor cells and combined it and worked with Tim Camp and myself. We got a fairly sizable NIH grant to do this, and we injected the combination of the cells and the matrix in a pig model. And we looked at baseline MRI and 1 month MRI and pressure volume loop. So we looked at histology as well, and we placed loop recorders to look for arrhythmias. These are human cells and a human-derived matrix into a pig. So we had to kind of do a 4-drug immunosuppression regimen on these pigs. We used that mapping system that was already in clinical trial use, but we used it in the pig model here. And we were able to show, at 2 weeks, 1 month, and 1 month later, that sizable human grafts could be detected into the pigs. So human cells were being tagged with this Ku880 marker, a mitochondrial marker, and we can sort of see human cells kind of all throughout. And when you see the interface with the host myocardium, you can see quite a difference. So these graphs seem to persist even out to 1 month later. And if we dial up in further and look into it, you're starting to see kind of the sarcomeric structural elements, including the myofilament, elements in it that have the remnants of that make us think about rather myocytes. And if we dial in even further, we label CX43, which is so-called a label for gap junctions. We're able to see some integration. So not only does there appear to be junctions between the human to human cells within the grafts, but also human to host. And whether that's going to be important or not, we don't know. And to what extent this has happened, we also don't know. So there's still more work ahead, but that's sort of exciting news. And we finally showed that there was did not show any significant ventricular tachycardia at all with this approach, whether it was the ECM alone, the cells alone, or the combination alone. There's one pig that did have it at baseline before therapy. So after the MI, had arrhythmias and had one episode of VT afterwards, but that was it. And when you look at the cardiac MRI that happened at 1 month, we are starting to see improvements in stroke volume as well as ejection fraction, and then load independence assessment of contractility reserve showed improvements in the cell-treated arms versus the controls. And so the summary of that work is that the combination of cells and matrix appears not to be arrhythmogenic. The graphs seem to persist even out to 2 months following injection, and there was initial evidence of donor to donor and donor to host integration, but that's still very preliminary. And the xenogenetic transplant is a challenge, and of course, there's immunosuppression related toxicities, which definitely influenced our work. And so finally, as we think about the next steps, we are preparing another grant. We've submitted it for a YO1 renewal to inject the matrix itself. And just to highlight one last little evidence behind the curtain, we hired Jamie Hernandez to our lab. She's an assistant scientist doing remarkable work now. And she has developed lines of iPSC-derived cardiomyocytes. And so this is a cardiomyocyte grouping. And it's a very slow pace, but if you watch carefully, you'll start to see a beat. And so what's the importance of this? Well, this is now a really new model system that many people have been trying to develop, and Jamie did it in our short few months here. And this could really be a way of being able to study how the cells behave in a pig model, a syngeneic pig model, without the need for all the immunosuppression and that part of it, at least to understand the biology, behavior, and integration characteristics of the cells. So the final take-home messages in the last, and I've got 10 minutes left, but cell therapy for heart repair has made tremendous progress. Success requires the correct cell type, precise delivery, and supportive microenvironment. And adult cells may offer benefits in selected patients, and we're kind of refining those trials, as you saw, for the CardiAMP program. Pluripotent cells offer remuscularization potential, and maybe selected cell types appear non-arrhythmogenic, like the CCPs. That seems to be a challenge. And then these cell-free biomaterials, things like that, what air can produce, may be a new frontier for cardiac therapy. And cardiovascular regenerative medicine may one day not be the next pillar of heart failure management, but far much more work is needed. And that is it for this. Thank you for your attention. I would be happy to answer any questions that are posed.
Great, thank you. Maybe we can stop sharing for a second.
Yeah,
And I have a couple of questions for you. Um,
sure.
One is, most of the animal work is relatively soon after the injury and the fibrosis development. Do you think there is a window by which cell-based therapy can be effective, knowing that over time there's, cross-linking of the matrix and a continued evolution of it that may make it more difficult to intervene? So thoughts on the timing.
Yeah, so I think it's going to, in my opinion, it's going to be very cell specific. And so think if we're talking about some of the easier to acquire, simpler cell concepts like bone marrow cells or adipose-derived cells or mesenchymal stem cells, easier to acquire and deliver and so forth, I believe that the pathways are to get this early post-MI in that milieu before late remodeling has happened. Because for those cell types, late remodeling is probably too late then. It's just probably not going to likely. There's just no evidence that bone marrow cells becomes cardiomyocytes, and natural responses to repopulate cardiomyocytes are really have been shown, but really small numbers. So prompting those in any sort of meaningful way will be very difficult. On the other hand, um, that's when you think about it as a trialist and as a clinician, when patients have an MI and you're in that early urgent, obviously the focus of therapy is opening the artery, and then they kind of in the stunned phase afterwards. It's very challenging to know who are those patients that are going to be destined towards getting a large heart and go on for a transplant versus those patients that are going to recover to some degree. And so that's point of, that point it becomes very challenging. And then, because you don't want to necessarily overtreat those patients, they're going to get better anyways, because you did the right thing, got the stent in or reperfused thrombolysis, whatever. But at the same time, you don't want to miss those patients who, had a big MI. And there are some biomarkers and there's some imaging tests, and we can try to, parse that out. It becomes really kind of challenging. I will also say that, in my experience, having done cell therapies in recent MI patients, there was a very famous Osiris 403 trial where we did way in the early days, did intravenous infusion because we didn't really have well-adapted catheters back then. We were taking people soon after their large anterior wall MI and infusing it. And I'll tell you, Lynn, it is really challenging to get people to, sign on. It really is. Don't have a life experience yet of heart failure, right? They just had an MI. They were feeling perfectly fine the day before. They were probably smoking their cigarette or, trying to take care of their diabetes or whatever it was beforehand, but they really weren't having chest pain. Then they had their MI, and now we're descending upon them, in the hospital or maybe a few days out of their, post-discharge. Do you want to be in a trial? Because we think you're going to develop heart failure down the road. And, that mindset became very challenging, So, while I think intervening early is going to be an important thing, how do we get that in practical terms is, I think, really a task for us trialists.
And then if you're going to administer cellular therapy late with established fibrosis, I know one of the things that's been shown is that matrix itself can cause cells that get embed normal cells to become fibrogenic. So do you worry that you're infusing cells into a fibrotic environment that they will um, turn more pro-fibrotic and potentially worsen the fibrosis?
Yeah, no, that's a really good point. I mean, I think that is probably true if there's sort of active and persistent injury happening. And for the most part, the type of patients or the type of animal models that we're talking about is a single event, and then the ischemia, sort of the ischemic injury, is sort of done, and then the scars sort of fully developed. And in the animal models that preset this in the cardiac condition, we're not really seeing that. We're not seeing bone marrow cells causing fibrosis or causing more worsening. In fact, it's quite the opposite. In fact, the literature has, enormous number of publications of injecting and infusing a variety of adult cell types and not showing worsening, in that regard, from using bone marrow cells or adipose cells, placental derived cells, a variety of cell types. It's only when you got to the clinical trials that we haven't been able to show that it improves things. So it's definitely, I think, in conditions like probably inflammatory conditions like lupus and other things where, certain diseases that have a persistent ongoing, degree of inflammation happening, and that those cues to prime cells to becoming fibrotic or, fibroblast proliferation probably persist. I'm not sure that that's to the same degree in this MI population.
Yeah. Yeah. Well, some of the data is independent of the inflammatory response, but the stiffness of the matrix itself can
Mm.
cause activation of TGF beta and profibrotic. But um, and then one final question, you focusing on delivery and trying to increase engraftment. How many cells do you need, given that you're using progenitor cells or stem cells by definition are supposed to be self-renewing and perpetuate. So what is your target?
Yeah, it's a really good question. I don't think we know. Um, the precedent is that the original embryonic stem cell paper, Chuck Murray's lab showed 1 billion cells, or were needed to show that sizable graft in the monkey model. Mike Laflamme is an investigator in Toronto who's been doing this sort of similar work, 300 million cells in a pig model. Our study did 200 million. We also did 300 million cells in our pig study per animal. These are monstrous
Yeah.
numbers of cells, and so in parallel, as we start thinking about the improvements, there's this whole manufacturing element in innovation, and how do we get these bioreactors up and running and efficient and cost effective to be able to manufacture such huge numbers of cells with the same quality and consistency that we would expect, from a regulatory perspective. So the answer is I don't know what the answer is yet, but that's the ballpark of what's being tested right now.
Great. Okay. Other questions? Okay. Not Chica.
I don't see any in the Q&A so far. But yeah, open to audience. If anybody has any questions, please unmute yourself and ask.
I will ask one final question then. You talked about a pig model, Chuck Murray's group using monkey, rat, mice. Can you give us a comparison? What what is the features of a pig, for example? Because I know they're very commonly used in for to study cardiac disease. So what is favorable about the pig besides their size, let's say?
Yeah, no, I think that's a really good question. So, I and others, Tim Camp and others, have really kind of moved towards the pig model because their the kind of infarcts that they get and the behavior of their infarcts are more similar to an MI in a human. Plus, it lends itself to testing human catheters, for human purpose catheters seamlessly. Finally, like the imaging that we're using, like MRI and CT PET and other things, kind of work really, really well using existing software tools, just on a pig model. And we have the Center for Biomedical Swine Research and Innovation. So on a very practical matter for our group, it's actually very easy to get pigs rather than, other animals like sheep and other, larger animals. The FDA is also really pushing towards a more large animal experience, trying to get closer to the human size and for those kind of dynamics. Um, the other part of it is, the physiology. A mouse or a rat, the heartbeat's running at a 500 beats per minute or so on. We can't, and it's hard to measure things like VT and things like that, the safety elements. And you can only really do that in a larger animal, which is a more heart rate that's sort of more similar to humans.
Yeah, great. Okay.
Dr. Raul, I had a question about the CardiAmp HF2 trial that you're enrolling. With patient selections, if I correctly remember, there were like these 4 criteria for NYHA class and certain amount of EF and NT-proBNP and cell population analysis. So these patients would have all these criteria met, right, to be enrolled, or was it like, yeah?
No, no. Yeah, yeah, that's you have to have all of those criteria, man. It's a very challenging, complex study, you know. Um, and yeah, it's not an all-comers kind of thing. And we did have to really narrow it down. Some of it was on our own making to kind of decrease heterogeneity in the patient population, but also some of it was kind of required by the FDA in terms of trying to treat more sicker people, who had really no options. That's the one thing I guess I didn't mention is these are patients that were already maximally revascularized to the point that they could be, reasonably. And so there was no other revascularization options. And also they were supposed to have been on maximally tolerated guideline-directed medical therapy, which kind of I showed you SGLT2 inhibitors in the milieu of timing of when they came out was maybe in the 30 or 40% range, but that was because of the timing. And so that was kind of the entry criteria. These are the true no option patients.
Great. All right,
Thank
well,
you.
we're at time, so thank you. Thank you, Dr.
Thanks.
Jha, Dr. Ravel. There's gratitude in the question and answer from family members of your patients. I think just attesting to the outstanding clinical care you give, combined with the outstanding research to make our patients' lives better. And that's what it's all about. So thank you so much for all of the work that you do, and for a wonderful talk.
Thank you.